Well, good morning, everyone. Hope you all are doing well. I am very excited to have you join. If you can go ahead and open up your chat box, I'm going to activate the chat box. Why don't you go ahead and spend a few minutes saying hello where you are logging in from. I am so excited to get started. Look forward to seeing everyone join very shortly. And we will get started soon. Thank you so much. Excellent. We have a few people who are just joining. I just wanted to do a quick little check. If you can hear me, and see my slides, do you mind going ahead and typing yes into the chat box, please? Wonderful. Great. And if this is your first time joining, welcome. How many of you all, it's the first time joining one of these webinars? All right. Welcome, Mandy, Asta, Michelle, Skylar, Colleen. Wonderful. Great. We'll get started in just a minute. I'm going to just shift the live stream to YouTube as well, and I will be back. All right, everyone. We are going to go ahead and get started. I am so excited to see each and every one of you today, and thank you for spending your evening, afternoon, morning with me today. Today, we are going to be covering a challenging, maybe dry subject, but I'm going to try to make it fun. We're going to be going through genetic terms and pedigrees. How many of you all have kind of struggled with these types of questions, either on NBMEs or UWorld blocks? Go ahead and at least either raise your hand or just put me in the chat box. Absolutely. And what I would do is just take a few seconds to reflect on what makes genetics so challenging for you. You can type it in the chat box or you can think to yourself, but what makes genetics so challenging if it is a problem area for you? Excellent. So many people are saying probability, calculations, the different definitions and how to apply them. Absolutely. Sometimes foundations wise, it's challenging to grasp these concepts as they can be a little bit more kind of up in the air rather than true practical pathology, etc. Some of it is definitely memorization. My hope today is to clear some of these doubts. And for many of you, this might be the first time you've joined one of my webinars or watched one of my videos. And I wanted to just briefly introduce myself. My name is Rahul. I am a practicing pediatric critical care physician, and I'm just about to complete my master's in medical education, which I'm super excited. It's been a long 2 years. One of the key areas that I've been extremely passionate about is helping students just like you prepare for and excel on the USMLE utilizing an active recall and vignette-based framework. Here is my email. I try my best to get back to everyone. So if you need to connect with me, kindly go ahead and email me. So I know that there are so many resources out there, and you guys are probably utilizing many different resources, but I do want to spend a few minutes telling you why my baby, essentially, HyGuru, is so unique. I have a three-pronged approach. Number one, all of my lectures are taught in an active recall manner. You're going to see a lot of questions throughout the session today. I also like to make links amongst different organ systems. So I really try to focus on integration. And finally, and this is what many students have said is the true value that HyGuru provides, I really try to frame these concepts in the lens of a test maker. And so one of the key buzzwords that I like to say is HyGuru, it's all about thinking like the test maker. And we go through systematic approaches to attacking questions and even understanding the clinical reasoning behind some of these questions. Because my goal, more than just an exam, is to make sure that you kick ass on rotations and beyond. So when I prepare with students one-on-one, I use this triad. I say, hey, we're going to be not only going through content, but we're going to integrate content. We are going to be focusing on how to approach questions. You're going to try to go through the question, and then I'm going to help you kind of change your thought process. I also focus, as you can see, my energy today is probably palpable through your study space and camera. And I really like to focus on creating that growth mindset for the student and helping them be efficient in things like a day-to-day schedule, making sure that UWorld blocks are reviewed in an appropriate manner. This is a depiction probably of some of your medical school lectures or even other resources. And that is the traditional med ed model, which is a very linear model. Didactics, a slide, and then some bullet points. But what I really like to focus on throughout my courses and lectures is focusing on making connections and kind of keeping you on your toes, synthesizing different areas, anatomy, embryology, physiology, and making sure that those neuronal connections are going to be interleaved as you go through the content. So one of the key ways that you can think of this lecture today, as well as many of my other videos, is I'd like to synthesize everything together so that then you're doing not only questions, but content at the same time. And you will see a brief depiction of that throughout this next hour. We have over 250 people joining us today from all around the world. And I think one of the key things that has made HyGuru such a fun project for me is that HyGuru is a family. I have been humbled to teach at many medical schools across the country. And now I have the privilege and honor to be a part of your preparation as we embark on this lifelong journey in medicine together. What I am very humbled to share with you today are a few announcements. Number one, I have just added about 8 to 10 hours worth of content to my pass-fail course. This is going to encompass many of the high-yield concepts that you are going to see this year on the USMLE. Secondarily, I focus a lot on test-taking strategy. However, sometimes I'm unable to tutor everyone one-on-one. So I have created a one-on-one tutoring-like course that depicts how to prepare as well as how to approach many different types of questions. If you're studying for step 2 or know somebody that is going to be studying for step 2, I do have my newly released rapid review course, which I'm going to be adding the surgery content in the coming 2 weeks. But first, you all are here to cover genetics, Hardy-Weinberg, and pedigrees. And I want to really thank you for being here on time, ready to stay active and engaged. Please note, I have one key disclaimer, and that is to make sure you cut out any distractions. Your phone, etc., put it away. I'm not going to be background noise today. I want to make sure that I give you the most time and attention right now for the next hour stay focused with me. I put questions in for a reason so that then you can stay engaged in the chat box. All right. So if you are ready to go ahead and get started, go ahead and type in yes into the chat box. Everybody ready? All right. Yoshida is. Carolina, Motion. Excellent. Wonderful. Wonderful. Well, let's go ahead and get started here. What we're going to be focusing on today is the application of genetics and principles. Now, on your exam day, genetic questions are going to come in two folds. Number one, they're going to give you a clinical vignette. Or number two, they are going to give you a research-based question. Now, what is very important for you to note is that when you are thinking of a clinical vignette, you want to recognize what diagnosis it is and then link the genetic term to that diagnosis. From a research-based perspective, what you want to think of is organizing the data into what is the intervention, what is the control group, what is the outcome that they are looking at, and then relating the genetic terms that you know. So what is important here is that whether you get a clinical vignette that is asking you to apply a genetic term or a research-based question, the key here is to think about genetic principles as a vocabulary. This is the vocab book that I used in elementary school. And today we're going to be learning a new vocabulary. So the way that I think about pathology as well as genetic terms is like learning a different language. You want to have that lens as you are going through this video today, as well as through your pathology lectures, because the moment you start recognizing that, hey, a genetic term or a diagnosis is just a vocabulary word that has a definition or a pathophysiologic story, you will start recognizing some of the key concepts that are tested in vignettes. What I like to do is I like to just cut to the chase. I don't want to start with every single term and then go one by one. This is the summary. You can log off after this. I hope you don't. But let's go through the key definitions and incorporate the vocab word associated. So what about this one? Both alleles contribute to the phenotype of the patient. Go ahead and type into the chat. What is going to be that vocab word? Excellent. If you're saying codominance, you are absolutely correct. Both alleles contribute to a phenotype. How about this one? Similar genotype amongst patients, however, varying phenotypes. What is that one going to be? And if you're saying variable expressivity, you're absolutely correct. Remember, genotype, that is what is coded. Phenotype is what is expressed. One gene contributes to multiple phenotypic effects. That's going to be pleiotropy. Pleiotropy is basically saying I have a mutation in P53 and I have cancers like osteosarcoma, retinoblastoma, colonic adenocarcinoma. One gene, multiple different phenotypic effects. Now, let's kind of reverse the script. What would be the definition of anticipation? Think to yourself. An anticipation is basically an increased severity or earlier onset of disease in each successive generation. Generation 3 is going to have it earlier than generation 2, or generation 3 is going to have more severe disease compared to the prior generation. The other thing to note here is trinucleotide repeat disorders, which is what we are going to be talking about throughout this hour, is related to the principle of anticipation. So the test-taking tip that I want to give you all is the fact that rather than memorizing the definition, solidify an example of the genetic term and understand the meaning. So a genetic term is the vocabulary word, and then understanding the meaning is the definition. So today we're going to be going through an application of genetic terms. We're going to be going through pedigrees, and then we're going to incorporate Hardy-Weinberg principles. One unique thing that I'm going to be doing today is I'm going to either first cover the content and then push to you a question, or I am going to start with the question and then jump into the content. And there are going to be tons of NBME style, NBME-like questions so that then we can really learn, integrate, and apply. Are you guys learning something so far? Just want to check in with you all. It's sometimes very hard when it's just a camera and me. Wonderful. All right, guys. Well, I appreciate your energy, enthusiasm, and please cut out all distractions. Let's go ahead and get started with our first question here. A 40-year-old male presents with subacute jaundice and shortness of breath. On physical exam, he has bilateral wheezing. Laboratory studies are notable for hyperbilirubinemia and an AST that is high at 110. Hepatitis panel is going to be negative. Chest X-ray shows diaphragmatic flattening. What is the likely diagnosis? Is it A, primary biliary cholangitis, B, Crigler-Najjar, C, cystic fibrosis, D, Wilson's disease, or E, alpha-1 antitrypsin? Excellent. And many of you have activated the illness script of alpha-1 antitrypsin disorder, and you are absolutely correct. Now, one of the key test-taking strategies that I like to use when I see different organ systems involved is that we have a systemic or genetic disease that we are dealing with. And when I see lung plus liver, as you can see here, we want to think about alpha-1 antitrypsin disease. These are patients who are going to get cirrhosis and are going to get early onset emphysema. Wonderful. So I want to reinforce that test-taking strategy, and that is that if you are going to see many organ systems involved in a vignette, you want to really think of two broad concepts. And those are, number one, if it's an adult, something systemic. What is systemic? It affects many organ systems. Maybe it's something hematologically, infectious disease, rheumatology, because inflammation can pervade all organ systems. Things like cardiology, where the heart is going to pump all of that blood that has some pathological issue. If it's a pediatric patient and you have multi-organ involvement, you want to be thinking of a syndrome or congenital issue. Now, on my YouTube channel, I have a very high-yield video that is called Genetic Syndromes. After today, I would encourage you to watch that video, or if you're watching this at another time, make sure that you go to that portion so that then you can really link the genetic terms with all of the syndromes, which I will be covering in that video. So the key principle here is to recognize multi-organ dysfunction. And as we saw in the alpha-1 antitrypsin disease, you do not have a ability to break down elastase. So alpha-1 antitrypsin is tasked normally to break down elastase. And what is high yield for us to know is that if you do not have alpha-1 antitrypsin, you then are going to have more elastase. And that elastase in the lungs is going to degrade elastin. Once it degrades elastin, you lose elasticity, which is the lung principle of kind of snapping back like a rubber band. No elasticity, you get a highly compliant lung, but air trapping because you don't have any elasticity. And that air trapping gives you a obstructive phenotype, which is characterized by a low FEV1. So lung plus liver, alpha-1 antitrypsin disease. And very important for us to note, the gross pathology finding for the lungs is going to be this flattened diaphragm on radiographic pathology, and then the microscopic pathology is going to be related to PAS positive globules in the liver, indicating the misfolded alpha-1 antitrypsin protein. What is important for us to know is that alpha-1 antitrypsin disease expresses a genetic principle known as codominance, where multiple alleles contribute to the phenotype. All right. What we're going to be doing is going deep into this concept of codominance. I introduced it with alpha-1 antitrypsin disease. We're going to be talking about it also in the context of blood groups. Now, there are three key principles that I want to highlight when it comes to blood groups. The first one is to recognize that if you're group A, that encodes for the group A antigen on top of the red blood cell. If you're group B, you get B antigen on the red blood cell. If you are group O, you have no antigens on your red blood cell. AB phenotype, when it comes to blood typing, is an example of codominance. That is where the antigen A and antigen B contribute to the overall phenotype. The other thing for us to note is that the blood type, just like I just said, is defined by the antigen on the surface. And the antibodies are going to be opposite from the antigen. As you can see, group A is going to have A antigen on the red blood cell, but in the plasma, you're going to have anti-B antibodies. Similarly, let's say group O is going to have no antigens on it. Well, it's going to have both anti-A and anti-B antibodies. This is very high yield for you to know, because when it comes to the universal donor, for example, you will see that the universal donor is going to have no antigens on it. Let's go through a NBME vignette style question. A 28-year-old female who recently delivered her first baby presents for a newborn checkup. The infant's blood type was B negative, and the mother's, I'm just going to put it in green, is going to be A negative. High levels of anti-B antibodies are noted in the mother's serum. The baby is relatively asymptomatic with no jaundice. What is the likely mechanism behind the infant's presentation? So it seems like in this question, mom is sensitized. As you can see, the mom is going to be having anti-B antibodies. And why is that? Because baby's antigen on the baby's red blood cell was B. So the likely mechanism here is the fact that maternal anti-B antibodies are IgM in nature. Why is this so important? Well, in this question, the baby is asymptomatic, i.e., the baby does not exhibit any signs of hemolysis or jaundice. And why I put this in here is to tie in a very high yield immunology point. And that is that, remember, IgM is not going to cross the placenta because it is a pentamer. It's very large. What crosses the placenta? IgG. So that is why when you are going to be thinking of something like Rh incompatibility, the first pregnancy is not going to be affected. It's going to be the second one when the mom develops IgG. So as you can see here, the IgM anti-B antibodies is within mom because of the fact that she was exposed to or sensitized from the baby's B negative blood. And if the baby has B negative blood, remember, on the baby's red blood cells, there is going to be B antigen on the red blood cell of the baby. All right, so with all of this blood type talk, I want to tell you all, what is my favorite blood type to teach to medical students all around the world? And that is B positive. All right, I know not many laughs on the camera. Hopefully you're laughing at home, but I don't call this a HyGuru test-taking strategy. I call this a HyGuru dad joke, and I hope that you enjoyed that, and I'm just making sure that you are paying attention here. Very good. Excellent. All right. So now what we're going to be doing is we are going to be talking about genotype versus phenotype. Now, genotype, again, it is the code, and genotype is defined as alleles, which are like kind of small Legos, come up and they make genes. What is going to be a phenotype? Well, phenotype are observable traits of the patient resulting from the genotype, as well as the genotype's interaction with the environment. So what is important for us to know is that some diseases that are going to give us a phenotype is not only due to the genotype, but environmental influences. And that's a really nice concept for you to really think about when it comes to virtually many genetic diseases. So the way that I like to think about a genotype is that a genotype is like the cookbook whereas the phenotype is going to be the actual dish that is going to be made. It's the recipe and the final product. Genotype is going to give us a phenotype. If you're learning something, go ahead and type in yes into the chat box. Guys, doing okay? All right, wonderful. Let's go ahead and keep going here. So what we're going to be doing is we are going to be comparing and contrasting two genetic terms. Number one is variable expressivity, and the other one is going to be pleiotropy. Now, with variable expressivity, patients with the same genotype have varying phenotypes. So they will say, I have a gene mutation here, but uncle has it like this, brother has it like this, mother has it like this. It is the extent of which the genotype is expressed in the phenotype. So the key word here is extent of which the genotype is expressed in the phenotype. And remember that the phenotype in variable expressivity, it's variable. So the phenotype has varying disease severity. We're going to contrast that with pleiotropy. Pleiotropy, you can think of it as one gene contributes to seemingly unrelated phenotypic effects. I have a gene of phenylalanine hydroxylase. I will get a musty body odor. I'll get albinism. I'll get intellectual delay and seizures. And so it is this concept that one genotype can lead to a variety of effects across organ systems. Now, I want to relieve some anxiety here. The USMLE will make it very clear. The NBME questions will make it very clear. And let's say in UWorld and NBME, you get this mixed up. Take some time, pause, create that Venn diagram in your mind so that then for future questions, you won't get it wrong. Let's go ahead and understand this even more. One of the key examples of variable expressivity is neurofibromatosis, where multiple family members in this autosomal dominant disease can have varying degrees of the cafe au lait spots. The plexiform neurofibromas can be of varying degrees, as well as the Lisch nodules. Remember that patients with neurofibromatosis are also going to have things like optic glioma. Because there is a wide spectrum throughout the family of how they can look, that's why it's called variable expressivity. All right, let's go ahead and apply this concept. A 30-year-old woman with family history of Marfan syndrome undergoes a routine health examination. She exhibits tall, disproportionately long arms, legs, fingers, a trait common throughout all of her family. Her echocardiogram was normal. Her brother has the same stature, however, has aortic regurgitation and has been admitted for concern for aortic dissection. Which of the following genetic mechanisms may be at present? Why don't you go ahead and pause the video and take some time to look through each of these answer choices and put into the chat box what you think is the best answer choice. Excellent. If you're saying variable expressivity, which is defined as the degree to which a genotype is expressed in the phenotype, you are absolutely correct. This is going to be Marfan syndrome. And remember, Marfan's syndrome is related to this very characteristic Marfanoid habitus. And Marfanoid habitus, the differential for the Marfanoid habitus, Marfanoid, is going to be Marfan syndrome. You're going to be thinking of homocystinuria and MEN2B syndrome. All right, very good. Nice integration here. Very good, guys. So one of the key test-taking tips that I will give you is that when you are down to 2, think about the concept or diagnosis each of the answer choices are assessing you on. And I really like for you to read this and internalize it because it's very important. Many students fall into the trap of saying, hey, they're trying to trick me here, or they're trying to trick me there, or I get stuck to 2 and I do not know their tricks. No, they're not trying to trick you. In fact, in this question, I'm trying to assess you on your differentiation and delineation of each of the genetic terms. So for example, the presence of two identical alleles at a gene locus, that is a homozygous mutation. The degree to which a genotype is expressed in the phenotype, that's going to be variable expressivity. What about this one? A heterozygous genotype producing an intermediate phenotype. Does anybody know what is that genetic term? Go ahead and type it into the chat. And that is going to be incomplete dominance. What is important for us to note is that incomplete dominance and codominance are going to be different. Incomplete dominance is a blend together. In the classic experiments with, for example, peas, if one pea was green and the other pea was yellow, something with incomplete dominance is a blend of both of those colors. For example, if you have a red flower and a white flower, they blend together to make pink. Codominance refers to no mixing, really. It refers to the fact that blood type A and blood type B are fully expressed and they contribute to the phenotype. The tendency of genes located close together on a chromosome to be inherited together, this is called genetic linkage. So what I just did was not only go through many different genetic terms, but I drove home the point that each answer choice is talking about some concept or some diagnosis. So when you are down to two or you're trying to process of eliminate, try to figure out what is the concept A, B, C, D is going for. Let's go ahead and go into our next question. A researcher is studying a genetic disorder caused by mutations in a single gene. Affected individuals display a wide range of symptoms, including heart defects, skeletal abnormalities, and learning difficulties. Which of the following best describes this phenomena? A, codominance, B, variable expressivity, C, pleiotropy, or D, heteroplasmy? Wonderful. One genotype contributing to many different phenotypes. You're going to be thinking, yep, absolutely, pleiotropy. Let's go through our next question. Which of the following genetic phenomena is most likely responsible for these findings? A 25-year-old man exhibits diminished facial expression and experiences a sustained muscle contraction upon tapping his thenar eminence with the reflex hammer. Before you put into the chat or go to the answer choices, what is going to be the likely diagnosis? Go ahead and type that into the chat first. Diminished facial expression and sustained muscle contraction upon tapping his thenar eminence with the reflex hammer. Well, the sustained muscle contraction is actually going to be myotonic dystrophy. And patients with myotonic dystrophy, they're going to have a pretty flat affect. They're going to have male pattern hair loss or balding, and they are going to have this characteristic hypertonia upon repeated stimulation. So maybe they will say that, hey, you're going for a doorknob and it is going to get stuck, so to say, your hand is. So the key thing for us to note is that myotonic dystrophy is going to be your CTG, trinucleotide repeats, and that is exactly what the answer is here. All right, very good. So remember that trinucleotide repeat disorders, they are going to exhibit a very important characteristic known as anticipation. And as you can see in this pedigree, we note that the dark diamond is showing us that there is congenital onset of the condition. And you see congenital onset of the condition in the last generation compared to a patient who is going to be in an earlier generation that had an adult onset of the disease. So the key thing for us to note is that the trinucleotide expansion is going to cause increased disease severity, and age of onset is going to be earlier in successive generations. With that in mind, let's go ahead and apply yet another vignette. A 48-year-old male is found by law enforcement homeless on the street. He has had multiple domestic violence issues. Now, in this case, your differential, yes, you see the MRI and the peripheral vision, etc. I want to be focused on the process rather than the outcome. And what you can be thinking of is, okay, is this going to be some sort of ingestion? For example, if somebody is going to be acting out a lot and is going to have that superhuman strength, you're going to be thinking of TCP ingestion. His family is contacted and says that he has been very threatening over the past few months. The other thing you can say with the aggression is you can say high testosterone state. So the patient during the interview is noted to be smiling intermittently and moving his arms and legs in an uncontrolled manner. So this is now activating a chorioathetoid movement. And with the family history, next sentence, his paternal uncle had some neuro issues and passed away in middle age. Now we have this specific brain MRI. So what brain structure may be affected in this patient? And if you're thinking Huntington, and if you're thinking caudate atrophy, you're absolutely correct. Remember that the caudate is part of the striatum, which is in the basal ganglia region. And the best answer is going to be Huntington's disease. So remember that when you are going to see no caudate peeking into the lateral ventricles, that absence of a caudate, that is going to be very characteristic of Huntington's disease. Now, in another color, not to be confusing, but just to integrate, if I said periventricular plaques, the best answer then would be multiple sclerosis. So just trying to mess around in that ventricle area, right? If I say periventricular calcification, C, obviously the vignettes would be different, but here is going to be your porch infection, CMV. This is so important for you to understand various diseases surrounding anatomical structures. I hope that this was helpful. You guys doing okay? Thumbs up? Excellent. We're going to probably end this live stream a little bit earlier because, you all are on it, and the material itself is actually, relatively compact in this webinar because I wanted to focus on high yield things. All right, so genetic inheritance pattern here is going to be anticipation, as well as this trinucleotide repeat, which is CAG. So speaking of trinucleotide repeat disorders, we are going to be going through each of them. And what I did was not only say like trinucleotide and then the disease, I gave you the vignette that is most likely to show up on exam day. Here we go. 40 to 50-year-old male patient, aggressive, flails his arm, writhing body movements, has a positive family history of this condition. You're absolutely correct when you're saying CAG for Huntington's disease. Friedreich's ataxia. This on your exam is going to be a 15-year-old male with broad-based gait, diabetes, and exam showing scoliosis. Patient also has loss of sensation in his feet. So this is going to be your GAA repeats. I say GA, Friedreich's ataxia. And what's important for us to note is that these patients are going to have cardiomyopathy, like, for example, hypertrophic cardiomyopathy as one of the key lesions in Friedreich's ataxia. CTG, this is going to be the 30-year-old male who has noticed himself being off balance and has been embarrassed to go in public because the hair has been falling out. Here's the key. Exam shows a failure to relax the hand after shaking the doctor's hand, and that is CTG for myotonic dystrophy. All right, next one. Fragile X, a patient with intellectual disability, big ears on exam, and gonadal enlargement. So when you have this triad, so to say, you're going to be thinking of Fragile X syndrome. Now, Fragile X is going to be a trinucleotide repeat disorder of CGG. And remember, these patients are going to have big testes. So I'll draw the C here to represent the testes. And they are going to have big ears. So CGG, that's how I remember it. Now, other causes of intellectual disability. If it's a female, you're going to be thinking of Rett syndrome. Remember, the MECP gene usually is tested. Intellectual disability, fecal alcohol syndrome. Watch for thin philtrum. And then also trisomy 21 is also a cause of intellectual disability. And, you know, this is the differential you want to be thinking of, especially if the child is not hitting school milestones or developmental milestones. Very good. Let's go through the next question. A 29-year-old female presents for a new patient visit after immigration from Europe. Her academic reports note intellectual disability. Height is at the 8th percentile. Her menses have been normal since age 14. This is called a pertinent negative. You're going to rule out things like a primary amenorrhea. On physical exam, she has edema of her hands and feet. And further testing notes that 44% of leukocytes contain 45X, whereas the remaining 56 contain 46XX genotype. What is the genetic term which describes this phenomena? And if you're thinking that this patient has Turner syndrome, one of the key genetic terms after you recognize the disease to link to Turner syndrome is going to be a somatic mosaicism. Now, a mosaic in art is a puzzle. It is multiple different pieces of glass or tile coming together to make something. And so that's what you should be thinking of with a mosaicism. A somatic mosaicism is going to be multiple genetically different cell lines within the body. They are all different pieces of the puzzle. This is typically going to be an acquired error after embryonic development. It's an acquired error after embryonic development. And what is high yield for us to note is that the milder forms or asymptomatic forms of Turner syndrome is dependent on the ratio of normal to the genetically mosaic abnormal cells. And that's why this patient did not have the classic primary amenorrhea, because the somatic mosaicism, she didn't have as many genetically different cell lines that may have caused this. So what we're going to be doing is comparing and contrasting what a somatic mosaicism is compared to a germline mosaicism. Now, a somatic mosaicism is acquired and it happens after fertilization. The patient has a disease such as Turner's based on the ratio of normal to abnormal cell lines. Remember that there could be a cell line that is genetically mutated, and that is going to progress throughout the patient, as well as a normal cell line. And the severity of that Turner's is going to be dependent on abnormal versus normal. The offspring usually in a somatic mosaicism is usually unaffected. Why? Because this happens after fertilization. It is a characteristic of the patient and the patient only. A germline mosaicism, however, happens right during fertilization. It is a mutation in either the egg or the sperm cells. That's why it's called germline. Usually, in a germline mosaicism, the parents are unaffected. However, the offspring of that parent is usually going to be affected. And that is how you kind of differentiate somatic versus germline, is if the offspring is unaffected, it's a somatic because the patient acquired it after mommy and daddy gave that baby birth. If it is germline, the offspring is affected, but when you look at mommy and daddy, they're normal. The other concept that I am going to be focusing on is the concept of uniparental disomy and imprinting. If you haven't followed me on Instagram, I do post a lot of nerdy diagrams, and this was one of them. And I was like, should I remake the slide, or let me just teach the Instagram carousel here? And so what we're going to be doing is integrating Prader-Willi and Angelman syndrome. Now, this is related to the concept of imprinting. And what imprinting is a concept that is related to methylation of DNA. Remember that methylation of DNA is going to mute DNA. And so normally, let's say in Prader-Willi syndrome, the maternal genes are muted, i.e. in Prader-Willi, mom is silenced, such that if you get a paternal mutation, you get Prader-Willi. Now, another way that you can get Prader-Willi is not just from imprinting, but let's say, for example, you got 2 copies of mom silenced. Well, 2 copies of mom silenced is going to have relatively the same phenotype as mom silenced and paternal mutated. So that's why we call it uni from one parent, parental disomy. You got 2 silenced genes, and that's why you got Prader-Willi. So what the classic, first aid and stuff teaches you is Prader-Willi, P parent or P paternal. The key thing for us to note here is that the P for paternal and Prader-Willi refers to the mutation that the patient has. So in Prader-Willi, yes, the paternal gene is mutated and the maternal is silenced. Flip the script for Angelman. In Angelman, the paternal is silenced, and Angelman, the maternal is mutated. But what's the other scenario? For uniparental disomy, who would you get it from? Mom or dad? Go ahead and type that into the chat. For Angelman syndrome, if we're thinking about getting it via uniparental disomy, who are you going to get those genes from? So if it's uniparental disomy, it's actually going to come from dad. So let's go ahead and go through Angelman syndrome. Remember, in Angelman, normally dad is going to be silenced and mom is going to be mutated. And if mom is mutated while dad is silenced, you get Angelman syndrome, which presents as seizures, ataxia, this puppet-like movements and laughter. If you are going to get 2 silenced dads, that's the uniparental disomy that you need for Angelman syndrome. I hope that this is helpful, and go through that cognitive gymnastics. You can either go the imprinting route with methylation and then a mutation, or you can get Prader-Willi or Angelman via uniparental disomy. Let's go ahead and go through probably one of the hardest questions in this webinar. Researchers conduct a study on HLA-DR genes to understand type 1 diabetes. They find 2 key loci of interest, HLA-DR33 and HLA-DRQ, and they are found on different ends of the chromosome. Further analysis shows that the combined frequency of DR33 and DRQ is going to be 0.2. Individually, DR33 has a 0.3 allele frequency, and DRQ individually has an allele frequency of 0.2. What is the likely genetic term describing this phenomena? A, linkage disequilibrium. B, heteroplasmy. C, codominance. Or D, segregation. What do you think is the best answer here? Wonderful. And the disclaimer that I want to make here is the fact that sometimes when you see these kind of vignettes, you're just going to like mindlessly associate, and that's fine. But let's say you're going through and you're getting some questions wrong, or you're having a little bit of error rate, or you don't understand the variations of the vignette. Then you really want to go deeper into the definition of that vocab word. So this is going to be linkage disequilibrium. Now, what is linkage disequilibrium? Well, what you notice here is that when both of these came together, they are going to have a frequency in the population of 0.2. And so what linkage disequilibrium is that alleles at two different loci are associated with each other more than just the general population. See, if you looked at DR3, which is 0.3, and you looked at multiplied by DRQ, which is going to be 0.2, if you multiply those two together, you are going to get 0.06. But when they came together as one package, they actually have a number that is 0.2, much higher than just them individually. So that is why it's called linkage disequilibrium. It's separate from the population if they are going to be higher when combined together. Next principle we're going to be talking about is Hardy-Weinberg. Now, Dr. Hardy and Dr. Weinberg were really two very talented individuals. Dr. Hardy was actually a mathematician, and Dr. Weinberg was a physician and also a self-taught geneticist. And they combined together and they created Hardy-Weinberg principles, which look at genetic alleles and population frequency, as well as the predictive analysis of them. The key thing that I want you to recognize is that NBME, UWorld, and your USMLE exam makes Hardy-Weinberg relatively easy. We're going to break it down over the next few slides. And I promise their intentions were to not make it bad for you on exam day. Now, when Dr. Hardy and Weinberg combined, they really created a message, and they said, we want you all to think about Hardy-Weinberg when you're obviously dealing with allele frequency, as well as genotype frequency. But they really wanted us to apply this only when populations were big. So if you have a small population, you cannot do the P plus Q and all that jazz. They also wanted to make sure that you applied this only when people have an equal chance of matching up together. They also said we can apply this P plus Q principle if there is no natural selection. Basically, no phenotype is superior than the other. And finally, they assumed that you do not have any spontaneous mutations, i.e., there are no new alleles that are allowed, no spontaneous mutation, i.e., no genetic drift, where a genotype kind of fades away in the background. And then each generation in genetic drift is going to change, but it was a mutation that caused all of this. Hardy-Weinberg principles are going to be contra genetic drift, and there are no spontaneous mutations that are allowed. So this is the let's get to the point slide. What we're going to do is we're going to be going through the equations that you need to know and how to apply them. Stick with me here. When it comes to allele frequency, P represents the normal allele frequency, whereas Q represents the mutant allele frequency. Remember, alleles make up a gene. And what's high yield for us to note is that P plus Q is equal to 1. And why is it equal to 1? Because P is going to be normal allele frequency percent, Q is going to be mutant allele frequency percent, and both of them have to combine to equal 100%. Now, in terms of disease prevalence, remember, you get genes from mommy and daddy. So Q squared is going to be representing diseased individual because it's a mutant allele and a mutant allele combined together, and that is going to represent the percent diseased individual. Now, phenotypic frequency is going to be the ratio of diseased compared to normal. Basically, how many Qs are there compared to the Ps, right? Because Q is the mutant allele frequency. And we represent phenotypic frequency via P squared, which is normal, 2PQ, Q squared is equal to 1. So P squared plus 2PQ plus Q squared is equal to 1. P squared is going to be the normal people. Q squared is the diseased individual. And 2PQ is going to be the heterozygous. So if we think about it like this, let's say that this is an autosomal recessive disease. RR is basically Q squared because this patient is diseased. Okay, very good. So let's go ahead and apply this. The key principles before we go into the application questions is to recognize that if the vignette talks about genotypic, phenotypic, or disease frequency, you're going to be thinking about the squared, either P squared, Q squared, maybe even 2PQ, because that's going to represent the genotype more. Whereas if they say the allele frequency, that is just the individual P, which is normal allele, or Q, which is going to be mutant allele. So the test taking strategy that I use for any sort of equations, this can even be a strategy that you can look at in biostatistics. That is that you want to take out your scratch paper on exam day. If you're noticing you're going to go down a calculation route, write out the givens. Then you want to isolate the formula that you're going to use, and then you're going to plug and chug. You're going to plug it in and get the answer. Okay? So 3 steps. We're going to practice these 3 steps. Before I move on, are you guys learning something? Everybody doing okay? Sai, Dolores, Jasmine, Yoshida, Ahmed, Michelle, Jaril. Wonderful. All right, guys. Stick with me here. We got this together. So let's go through this. In a population, the percentage of patients with Gaucher's disease is 16%. What is the frequency of the recessive allele? Let's go through this. First thing that we have to know is 16%. That's the disease frequency. That is going to be your Q squared. Next, we are going to isolate the formula. The square root of Q squared gives us Q, which is the frequency of the recessive allele. That's what they're asking us about. So we're just trying to solve for Q. And so now plug and chug. Square root of 0.16 is going to be 0.4. So where did we get this from? Well, this is going to be the mutant as the genotype or the disease. And then in order to get the allele, remember allele is Q in this case, mutant allele, you have to take the square root. All right, let's practice this again. In a population of patients with Gaucher's disease, the percent frequency of recessive allele is noted to be 0.4. That 0.4, does that represent P? Does that represent Q? Does that represent 2PQ? Go ahead and type that into the chat. What is going to be the 0.4? Yeah, it is the frequency of the mutant allele, which is Q, is 0.4. So what is the frequency of the dominant allele? So what are we solving for? P. So what we're going to do is fill out our givens. They gave us Q is equal to 0.4. We're going to isolate the formula. P plus Q is equal to 1. And so now P plus 0.4 is going to equal 1. And so solve for P and you get 0.6. 3 steps. We're going to be fill out our givens, isolate the formula, and plug and chug. Let's go through this. Researchers studying Gaucher's disease note a dominant allele frequency of 0.6. What is this given? Is it P or Q? Go ahead and type it into the chat. I want everybody to answer, please. Yep, exactly. And the recessive allele is 0.4, so that's Q. What is the percentage of the heterozygous carrier genotype? All right, fill out our givens. Our given is P is 0.6, Q is 0.4. Isolate the formula. 2PQ is the heterozygous genotype frequency. So we have 2 times P, 0.6, times Q, 0.4, and that gives us 0.48 or 48%. And remember, these are all percentages. Go ahead and take about 1 minute. Go through this question. If you're watching it later, pause the video, and I want you all to put in your answer. Go ahead. Excellent. Very good. If you are saying that the carrier status is 2PQ, you are absolutely correct. And you are now just a little bit better in Hardy-Weinberg. Yes, it's going to take practice, but hey, you have now the major foundations. So Hardy-Weinberg, the carrier frequency is going to be 2PQ. Remember that if they say that the frequency of normal people is going to be a certain percentage, that's P squared. If they say that the frequency of diseased individuals or phenotypic presentation of patients, that's going to be Q squared. And remember that an autosomal recessive disease, very high yield for us to know, an autosomal recessive disease usually does not affect every generation, and there's no sex predilection, i.e. it doesn't just affect males, it doesn't just affect females. It has no gender bias. Autosomal recessive skips generation, no sex predisposition. All right, let's go ahead and go through this application-based question. A 32-year-old man comes to the office because of a 2-year history of abnormal movements of his hands that are worse when he feels angry or depressed. His maternal grandmother and mother, both now deceased, had similar symptoms with the onset at the ages of 53 and 42 years, respectively, which is, older than this patient here. Neurological exam shows normal muscle strength, bulk, and tone. There is no intention tremor dysmetria. That's a pertinent negative to cerebellar disease. Sensation is going to be intact, and he is unable to fix his gaze on one point or protrude his tongue for more than 30 seconds. Deep tendon reflexes are hyperactive. Mental status exam shows no abnormalities. Which pedigree correlates with the genetic inheritance pattern? Go ahead and type that into the chat. What do you think is the best answer here? A, B, or C? Very nice. So if you are thinking B, autosomal dominant, you're absolutely correct, because autosomal dominant, that affects every single generation. Remember that something like A is autosomal recessive. Something like C is going to be primarily X-linked. And why is that? Because it usually is just affecting males. X-linked disorder usually affect males. Very nice. Good job. We're going to end today with talking about my test-taking strategy towards pedigrees. Now, I have this approach. I first look at the generations affected and the sex predilection. Does it affect boys, girls, etc.? What I also want to note is the basic terminology. This is a normal female. This is a normal male. this is going to be a diseased female, and this is going to be a diseased male. Okay, so normal female, normal male, diseased female, diseased male. If it is going to affect every single generation, it is going to be dominant. If it's going to skip generations, it's going to be likely recessive. These are general principles. If there is a predilection towards males, think about X-linked. If there's going to be a predilection towards moms that are going to give it to all of her offspring, think mitochondrial. And that it is as simple as that. Autosomal dominant, males and females equally, every generation. Autosomal recessive, skips generations, males and females kind of equally. And then X-linked, males only. And then mitochondrial is mom to offspring. So this is autosomal dominant. And as you can see, it's affecting both males and females in the purple, and it is affecting every generation. X-linked recessive. As you can see here, males are only going to be affected. Now, if you think about X-linked recessive, moms who are carriers, i.e. they're unaffected, they are going to be X capital H, X lowercase h, can combine with unaffected fathers. Let's say that we are doing something here. What we have to know is that half of the sons can be unaffected, whereas the other half of the sons will actually have hemophilia. And that is looking at it like this when you do the Punnett square. The other thing for us to know is that typically females are spared in X-linked recessive disorders. As you can see here, the dad is going to give the normal, and 50% of the daughters are going to be carriers. So why are males usually affected in X-linked recessive disorders? And that is going to be because the dad gives the Y chromosome to the son always. Dad gives the Y chromosome to the son always. And so you have a 50% chance of inheriting either X capital H or X lowercase h. Let's go ahead and go through this question. A 28-year-old male presents to the physician for a 3-day history of dark urine. The patient wears hearing aids and glasses. A dipstick shows 2+ blood. Renal biopsy shows an apparent splitting of the glomerular basement membrane. Which of the following inheritance patterns best describes this condition? A, autosomal dominant, B, autosomal recessive, C, mitochondrial, D, polygenic, or E, X-linked. What do you think is the best answer here? And for extra points, what is going to be the diagnosis here? Excellent. If you are saying Alport syndrome, you are absolutely correct. And remember, Alport syndrome, X-linked. What I want us to note is that this is a genetic mutation in type 4 collagen. As a result, you can get issues with hearing, issues with the eye, as well as hematuria. Because remember, type 4 collagen makes up your basement membrane. Now, here's an integration here. Goodpasture syndrome, which is going to be anti-basement membrane disease, that is not genetic as much as it is an autoimmune type 2 hypersensitivity, autoantibodies to the type 4 collagen. This typically presents with hemoptysis, so coughing up blood, hematuria, and in your diagnostics, you will get a linear immunofluorescence. So as you can see, I kind of linked the Alport can't see, can't pee, can't hear, high C. I kind of linked them together with Goodpastures because of the fact that they both surround this concept of type 4 collagen and basement membrane. The other inheritance pattern that I want us to go through is mitochondrial inheritance, and that is related to the genetic term of heteroplasmy. Now, what is heteroplasmy? That is different mitochondrial genomes that are within a cell. And sometimes those mitochondrial genomes are mutated within a cell. And so what is very important as a genetic principle is that mitochondrial DNA is usually passed on from the mother, mom to offspring. And so if you have mutations in the mitochondrial genome, you are going to affect mitochondrial heavy organs. That's why when you think about mitochondrial encephalopathy, lactic acidosis, and stroke-like symptoms, or mitochondrial encephalopathy and ragged red fiber disease, MELAS and MERF, typically these mitochondrial disorders affect brain and skeletal muscle. And what's the general principle here? Well, if you have a bad mitochondria, you have poor OX-FOX. What's that? Poor oxidative phosphorylation and poor electron transport chain. So the organs that need the most ATP, brain and skeletal muscle, are usually going to get affected. And so that's why when you have bad mitochondria, typically these patients who have mitochondrial diseases are going to have lactic acidosis because it represents a shift from aerobic to anaerobic. Many of your mitochondrial diseases are going to have this characteristic buzzword attached to them called ragged red fibers. And remember, I said that mitochondria is messed up in mitochondrial diseases, and that mitochondria being messed up can cause you to have structural disorganization within the muscle fiber. And that's why you get the ragged red fibers. So I like to just make a little parallel or riddle, so to say. Apple green birefringence on Congo red, that is going to be your amyloidosis. Ragged red fibers, that's going to be your mitochondrial diseases. And remember, it's mom to the offspring. So just like this, we see here, mom is affected. All of her offsprings are affected as well. Here is going to be a mom affected, all of the offspring. However, you don't see that on the other side. What is important here is that if you have not followed me on Instagram, go ahead and give me a follow. I would love to continue to push you cognitively on your breaks. Say that you're checking Instagram in between studying. I put daily questions and would be more than happy to respond to you if you have questions, etc. With that, I'm going to end. I really, really appreciate everybody joining me today and spending just a brief portion of your study day with me. I really look forward to seeing you all in many of my courses. I like to take a very personalized approach. Just stick around for a few seconds and I'll just give you a little bit of a brief overview if you do not know or are not familiar with my courses. I have the Pass-Fail course. The Pass-Fail course synthesizes in 80 hours the key USMLE concepts before exam day. What is high yield for us to know is that it's application based. I do have many flow diagrams, many Venn diagrams. This is perfect for you if you are stuck on NBME percentages like a plateau, if you need comp or CBSE that you need to prepare for, or you're within your dedicated study for step one, bam, this gives you great organization where you do UWorld in the morning, review your UWorld, and by 3 p.m. or so, you're shifting into this course. Another course which I want to also highlight is the Test Taking Strategies course. Just look at the curriculum here. This course gives you a systematic approach for different types of questions. Oh, how do you approach an EKG question? How do you approach a drug ad question? How do you approach a multimedia question where they tell you to put their headphones on? In these series of videos, in this course, not only do you get a study plan that helps you organize your UWorld notes, but guess what? You also are going to go through the videos where I introduce the strategy, I demo the strategy, and then bam, you apply the strategy. And my hope is that as you go through that Test Taking Strategies course, you say, okay, Rahul has equipped me with the tool belt. Now let me apply it in UWorld and NBME and see your percentages and your confidence go up, up, and up. If you have not connected with me on any of these platforms, Instagram, Facebook, Reddit, I'm on TikTok, I'm on YouTube, I would highly encourage you to. And if you found today's session very valuable, I want you all to just spend a few seconds, if possible, to just put in to my review website. I'd love to highlight you. And I'm going to also be selecting people that I can send my HyGuru coffee mug. So I will be selecting people kind of as a raffle. If you've posted a review, I can reach out to you via email and I'll get your address and I'll send you some study swag so that then you can stay inspired and well caffeinated, or tea or whatever you is your drink of choice throughout your preparation. Thank you guys so much. I'll see you next weekend. Actually, I'm going to not be on call. So guess what? We will do one more webinar going through more step 2 stuff if you guys are wanting that. And we will go from there. Please, before you leave, if you don't mind typing in one thing that you learned, any feedback, questions that you have, I'll stick around for a couple minutes here.